Something else is that we're changing the way we're thinking about what means refractory migraine, what constitutes refractory migraine. We say it's frequent, it's disabling, and several treatment failures have occurred. And there's this conceptualization that the more and more treatment failures one experiences, and this is with any medical condition, the more refractory that disease state is and the harder it's going to be to treat. What's fascinating is what we're seeing in these clinical trials is that the more treatment failures one has, the better they might even do. And this again speaks to the mechanisms of migraine and the mechanisms of treating it. If you fail to respond to these non-specific preventive treatments that don't directly target CGRP, maybe that's the reason why. We're getting closer to a root cause, not the root cause, because I think there are probably multiple, but getting closer to a root cause or a root contributor to the perpetuation of migraine disease. So if you can treat it at the ground level with a treatment that targets CGRP directly, you may have better success where you've experienced failure before.
It's been really impressive to me in my practice, actually, that some of my patients who are the most refractory, who are in the hospital and in the emergency room and in the infusion center and have been through everything, and some of them have had really miraculous responses to these drugs.
Have you noticed that too?
Yeah, I have noticed that, but I think that there's subgroups. There are definitely these patients who respond, and then there's subgroups where it just doesn't seem to have any benefit. And clearly, CGRP is not the only chemical involved in driving.
Why don't we stop it calling it migraine? Why don't we call it migraine, the migraines, just like we have the epilepsies? That's really what we're dealing with, a phenotypic manifestation of multiple underlying disorders. And perhaps as a subset of the migraines that are CGRP dependent, if you give a drug for, the new terminology is no longer grand mal or petit mal, but the old days, if you gave a drug for one, it made the other worse and vice versa. Maybe we're dealing with the same thing in the migraines. We need to change our thinking. What you said is very important. Every other prior trial would exclude people who failed, people whose drugs failed them twice. Did I get that right? And now we've come to the conclusion, all that does predict the ability to get a greater effect size comparing active drug to placebo. That's new. And I think the point you're making is exactly that. The other point is that in some of the trials, they allowed concomitant preventative medicine, particularly topiramate, and the data clearly shows the antibodies work just as well alone or with a concomitant medication, which establishes exactly what we've said, co-therapy may be the best.
Medication overuse as well. For patients who were in those trials who were overusing medications, symptomatic medications, not butalbital and not opioids, but mostly either triptans or non-steroidals. And they also benefited just as well as everybody else did.
I mean, I think
and were able to reduce their use of symptomatic medication.
Yeah, I think it's very exciting data that were presented at this meeting in terms of what Deb just said, where in the studies for chronic migraine for these monoclonal antibodies, and Richard Lipton presented data for both fremanezumab and erenumab in this meeting, and Deb was moderating. The majority of patients with chronic migraine converted to episodic migraine with these medications. The majority of patients with acute medication overuse converted to non-overuse with these medications. It's really shifting the way that I practice in terms of a patient coming in who's overusing combination analgesics and triptans. I can put them on these medicines, have a discussion about it, but be relatively confident that there's a greater likelihood than not that 3 months down the pike, that patient is going to have a very dramatic use of these, of what had been a previous overuse, with the potential for gastroenteropathy and nephropathy and all of the problems that the overuse causes.
I've almost come to the opinion that the reason when you failed multiple drugs, the next drug didn't work, is they were all working by the same mechanism.
Been failed by.
Did they get it right? Or failed by? And the other point is, so let us say what we have learned is that we eliminated 2 myths. Drug failure does not predict drug failure. It predicts failure of a drug that has the same mechanism. And the second point is that the idea of detox first, prevent later, I would say is medieval, with the exception perhaps of opioids and perhaps butalbital.
Yeah, I think it's important to say that opioids and butalbital overuse was excluded in these studies, and we do not know whether these medicines would have any impact in that setting.
But in the United States and the civilized Western world, it's prevent first, detox. In the barbaric Europe, they make people go cold turkey first, and then only if they don't do well do they get prevented. Let's move on now to patients of yours. You talked about one or two. Anybody have any good examples of patients who were resurrected? I call this almost resurrection therapy, bringing patients back from the dead. It's patients who we've had in our practice for years and nothing worked, and all of a sudden, I saw a kid the other day, missed out of school for the last 2 years, gave him one of the antibodies after we tried a lot of other things, and he's headache-free for the last 2 months. It's amazing, but tell us about it. Yeah, Mr.
I have a pretty dramatic responder, somebody who not only has migraine, but has hemiplegic attacks, ataxic attacks, demonstrated gene mutations, has tried so many different medications, and gets some benefit and therefore is on about 20 of them. Not all of them are daily, but so she's got several preventives. She's also got psychiatric medications for her comorbidities, and she's got an array of abortive medications from which to choose. This type of person would have been excluded from the trials due to the multiple manifestations of migraine. And she was a bit hesitant to try any of the new products right out of the gate. Managed to wait 3 months before going for it, and had an amazingly dramatic response. Within 4 days, was getting breaks in her symptoms. Now, her symptoms were constant. Constant pain to one degree or another, constant degree of sensory sensitivity, and very easy to trigger these ataxic attacks or the hemiplegic attacks. Then after her second dose, she started getting longer and longer gaps. And she came to me right about at that point after her second dose and was thrilled to report that she had only had maybe 8 migraine days that month. And the rest of her symptoms were minimal, if not gone. I saw her again after a few more months, and it was even better.
I think that may be the rule as opposed to the exception in people who start to respond.